Hello, Johar, and Namaste to all watching this. I am Dr. Shivangi Shankar, a medical doctor by training and a researcher implementer in practice. I welcome you to the very first episode of Climate Impact on Sexual and Reproductive Health, an initiative by PCI India where we dissect, simplify, and prepare for climate change. To give you a little context, according to the 2025 Lancet Countdown on Health and Climate Change, heat-related mortality has increased by approximately 23% since the 1990s, with recent estimates averaging around 546,000 heat-related deaths per year globally. This is approximately one heat-related death every minute. So the time for metaphors is past, and fatalistic attitudes will get us nowhere. We have all heard, felt, and seen climate change, be it heat, cold, or storm. Our lives are inevitably affected, and the health impacts are already being documented. While climate change is now widely recognized as a public health crisis, yet its effects are neither evenly distributed nor documented. It is known how gender, poverty, and social inequality shape vulnerability to climate change. Yet we barely talk about how these same forces shape sexual and reproductive health risks, especially when we talk of climate change. SRH is not peripheral to climate change, it is entangled with them. Today's conversation sheds light on this intersection. SRH, climate, and environment, often talked about as important areas deserving of attention, yet rarely together. Our guest today for this important conversation is Medha Gandhi. Hi, Medha, glad to have you with us today.
Hi, Shivangi. Thank you very much for having me, and thank you very much for creating this platform for such an important conversation.
Thanks, Medha. To give an introduction to our viewers or listeners, Medha is a global health and development professional with 25 years of experience advancing developmental goals with a focus on gender issues, women's sexual and reproductive health and rights, and women's leadership. An honorary fellow of the Indian College of Obstetricians and Gynecologists, Medha has worked extensively across maternal health, family planning, and adolescent health, with significant contributions to policy and program design. Medha leads a boutique consulting firm, Counterpoint Impact Advisory, working with a wide range of stakeholders. She has worked with several leading organizations, including Bill and Melinda Gates Foundation, IPAS, SEDPA, now C3, and CARE. Her work has included evidence-informed policy, introduction of innovations and services at the national and state levels, prioritizing adolescents and young people, and system strengthening. Climate is a priority focus area for her, and she has been leading research and design on the intersection of climate and health. She has recently published in The Lancet and continues her inquiry. Really, really grateful to have you with us today, Medha, once again. And without wasting much time, I'm going to jump right into the questions. And before we go into the depth of things, I want to know, what do we currently understand about the physiological impacts of climate change on sexual and reproductive health? Over to you.
Thank you, Shivangi. I think you started us off very well by quoting some very important data that highlights that the time is really now and we can't be waiting anymore. What climate exposures are already doing is that they're changing reproductive biology and pregnancy outcomes. And also important to note this is that it is possible to measure this. Very often, when we work in public health, we're very defined by what we measure. So, we have evidence to show that the impact of climate exposures on reproductive biology is measurable. Now, whether it is extreme temperature, precipitation changes, air pollution, urbanization, each has its own impact. As per available evidence, however, the most notable at this point in time are extreme heat and air pollution. The strongest and most reproducible evidence that we have links heat exposure during pregnancy to higher risk of preterm births, stillbirths, and low birth. Large systematic reviews and meta-analysis across many countries led by Dr. Lakhu report consistent associations between maternal health and exposure, maternal heat exposure and preterm births. And I think reviewing these systematic reviews, especially the one that I mentioned, are very important to help us in thinking about program design. And I'm not saying redesign, I'm saying program design, because I think we need to come up with a more innovative way of looking at this globally. When we specifically talk about men, spermatogenesis is highly temperature sensitive. What is spermatogenesis? You may already be aware that this is a process by which sperm are produced in the testicles. Now, this is very sensitive to heat as well as pollution. Meta-analysis find higher ambient temperatures and heat stress are associated with low sperm count, reduced motility, and emerging studies are also linking air pollution, particulate matter 2.5, to increased sperm DNA fragmentation. Now, these are important plausible mechanisms for population level declines in male reproductive indicators. And this is not just limited to men. It has an overall impact on how we are programming for our reproductive health services in any country or globally. And thereby, yet another very important call to include men and boys in programming from the beginning and being climate resilient. There are also indirect physiological pathways. The Lancet Countdown has highlighted that there is climate driven expansion of vector-borne diseases. There is also an important impact of climate, nutrition, and within that, it is the crop diversity and therefore the availability of nutritious foods, as well as completing your calorie count. These are such important indicators. And from that, we can, of course, get into maternal nutrition, micronutrient deficiencies that impact fetal growth. So there are both direct and indirect impacts. And we need to be mindful that as we are designing programs, we are being climate resilient from the beginning, Shivan.
Right. Thank you, Medha. Really interesting because we rarely talk about the impact of climate, especially on men. So SRH often counts in women and especially the maternal phases, but this is something that often gets left out. So thank you for pointing that out. I want to move a little bit away from the biology of things. And I want to talk about how are these risks related to SRH shaped by the social and economic conditions? If you can tell us a little bit about that, Medha.
Hmm. How I see this is that climate is a risk multiplier. What it does is it amplifies pre existing inequalities that determine who gets timely, safe sexual and reproductive health care. And to allude to the point that you were making, yes, it's very important to include men in this conversation. Equally important it is to include boys in this conversation. And as I've been reviewing a lot of literature in this space, it's also been a revelation for me that we have very limited insights on adolescent boys. There are far and few studies that highlight what is it that climate is doing on, how climate is impacting adolescent boys and what is it going to lead to when it comes to overall sexual and reproductive health outcomes. So I do think that that's an important area that we need to focus on. But you specifically wanted me to talk about the social and economic conditions and how that impacts sexual and reproductive health. Um, we normally, when we look at sexual and reproductive health, we look at clinical services, right? It's seen as a clinical or an outreach service. To me, one of the most important areas that matter are service and supply chains. And over the years, we've seen globally, and especially in South Asia, we've seen supply chains become very robust, whether it is for vaccines, whether it is for drugs, commodities, and of course for SRH services. We've seen them become very robust, and there is enough evidence to show that how that has improved access. Now, we're also aware that there are extreme weather patterns that we're watching. We're, however, looking at them as disruptions. We look at flooding or displacement as one. We see extreme heat as one disruptor. What we need to now acknowledge is that these are part of our routine day to day life. And we need to relook at our supply chains, our service delivery design in a way that's incorporating extreme weathers. And that is very important so that we're ensuring that there are no breaks in contraceptive continuity. There are no delays in antenatal visits, and they continue as streamlined as they're meant to be. And that women who choose to terminate a pregnancy are able to come in early for both confirmation of pregnancy and a decision about continuation or discontinuation, so as to reduce impacts on their health. There's also, of course, humanitarian and disaster studies that show these pathways repeatedly. So we need to be mindful of building a service and supply chain that is resilient and that is factoring in climate conditions from the get-go. There are also economic shocks that change fertility intentions. And, we've got enough evidence that shows how overall healthcare has an impact on household income. When we look at this specifically with reference to sexual and reproductive health, this also has an implication because we need to be mindful that the way climate factors are, they impact ability to travel to health facilities, the kind of expenses that come into play when we're looking at say low birth weight or stillbirths or other complications during pregnancy which we had not factored in. A cohort that is specifically impacted is women in the informal workspace or people who have precarious jobs and are particularly exposed. And we need to be mindful that in such population subgroups, when it comes to contraceptive access, fertility decisions, there are increased challenges and vulnerabilities. And of course, there is differential exposure, whether it is air pollution, whether it is impact of heat or concentration. And these are concentrated in poor urban neighborhoods and industrial zones. So we need to be mindful that when we're designing programs, we're looking at the rural or the urban as a homogeneous category. But we need to be more intentional in identifying what are these pockets and having a more hyper-local approach where we're looking at low income and marginalized groups such that we're producing clear equity gradients in risk and outcomes and serving the populations that we aim to serve. Um, so while climate doesn't necessarily, Shivangi, create new inequalities, what to me it does is that it amplifies or stresses the weakest links, whether it is in the health system, whether it is in population subgroups, or even for that matter, health workers as they maneuver through supply chains serving the poorest households. And we need to be mindful that in this whole process, oftentimes the existing inequities get amplified further.
Right. Thank you, Medha. A lot of things to unpack there. All right. So going back to what you were saying earlier about how we need to maybe stop seeing these as disruptions. They're not just extreme weather events that happen once in a while, but rather these are something that we have to factor into our planning and design at this point in time. So if I speak specifically for the health systems, whether you want to define it as health services or as you will, what do we need to make these more resilient in the larger sense?
I think that is a very straightforward response. We need to mainstream climate risk into routine health system planning, whether it is from a data perspective, workforce planning, workforce protection, decentralizing supply, monitoring programs, and for me, something that's very, very critical, self-care and of course, financing. If we see it as planning at a certain point in time for a certain issue or for a certain climate condition, then we are introducing strategies or influx into the health system at different points in time. For me, it has to be mainstream. Our program has to include the changes in the climate conditions and not about responding to climate shocks, but building climate variations into day-to-day programming. Now, having said that, let me see if I can explain that in a little more nuanced way as to what do I mean by mainstream climate risks into routine health system planning. So, for me, the first point here would be making climate risk visible in budgets and plans. What is on paper, what is budgeted, what is written down, what is articulated is what becomes our guidebook for implementation. That's our playbook. And here, what I would like to suggest is that we look at departments of health at the hyperlocal level. And this doesn't necessarily have to be a national agenda. The national guidelines have to be there for reiterating the fact that we need to be climate resilient in our programming. The Department of Health at the district, the provisional levels, whatever the geography in different countries may be, the geographical classifications may be, the hyperlocal departments of health, it is upon them to map local heat, flood, pollution, and other disruptions and translate that into the localized district provision level service continuity plan. And from there, that is what creates the scaffolding for staffing, for availability of supplies, for outreach, for service delivery, and building that into national plans. Whether we look at the WHO, look at the COP30 synthesis, we look at the Lancet countdown, all of these have been recommended in all of these platforms to say that we need to integrate climate health planning into national strategies and have a decentralized approach there. So that's my first point, which is around risk visibility in budgets and plans. My second thought would be around focusing on our health workforce and facilities. Every time we design our programs, the cohort that is often taken for granted is our health workers, right? Human resources for health. And a large majority, Shivangi, you would agree, are women. Whether it's at the front line or it is at healthcare facilities, we have a large number of women in service delivery. To be able to offer high quality services, we need to invest in our own human resources for health. And all of these climate conditions impact these service providers as well. A lot of them are older in age, if I may say so, and maybe experiencing physiological changes to their body which get impacted or exacerbated as a result of whether it's heat or precipitation or air pollution. And we need to be mindful that we provide heat safe working conditions. We have emergency power, making it safe to work, climate proofing, whether it is from precipitation or air pollution, so as to be able to invest in our workforce so that they're able to deliver high quality services. And another area for me, which I had mentioned in the previous discussion also, which is around strengthened supply chains and decentralization of commodity availability. And within this, I'd like to highlight the importance of self-care, task sharing, looking at leveraging telemedicine, looking at innovative technologies like self-injection, focusing on midwifery-led care, which is at the community level, so as to ensure that contraceptive supply disruptions are minimized, antenatal care continuum is maintained, adolescent girls have access to services and information, and our health workers are able to respond to the needs that clients have. And of course, all of this requires a platform which is of high quality granular data with early warning systems built in so that resources are targeted to geographies where populations are most at risk. Having said all of that, it doesn't mean that we don't have to look at service delivery and strengthening capacity building efforts, and of course, improving our data and monitoring systems, which is an ongoing process. But I do want to highlight these points because for me, resilience is not a separate standalone project. What it means to me is retrofitting everyday health systems so that they keep delivering when climate stress arrives.
Right. Thank you so much for sort of breaking that down so easily and simply. I think because we're trying to actually make sense of these things for people who maybe work in SRH. There are people who work with climate, and then there are people who are trying to make sense of these intersections. And I think it's very essential for all of us to understand how these intersect. And so those explanations really helped. I want to follow up on that a little bit. A lot of things that you said, in my mind, I'm seeing that also require a lot of convergence from other sectors. The retrofitting can't happen only through the health services or even the health department at the government level. How do you think organizations such as ours or other NGOs or community based organizations, or even I would say community members themselves, how do you think they can play an active role in supporting this resilience building process?
That's a great question. And I would take that a little further to also include academic think tanks, professional associations, as well as private sector into this cohort so that we're able to be more comprehensive about how we're addressing this. See, we're so used to looking at it as an NGO-led, donor-initiated, government-led intervention, and we're so defined by what is it that the public health system offers. The impact of climate is across geographies, and it's across systems, so we need to be mindful how we're doing that. So from the private sector lens, I do think that bringing about cutting edge research when it comes to newer innovations, diagnostic techniques, drugs, learning from supply chains that work for a lot of other commodities, which may not necessarily be for health, but are there opportunities for us to learn and think outside the box to be able to make our systems more resilient? And I think for the traditional development sector, which is implementing organizations like yourself and many others, I do think the opportunity is about what is it that we can do to amplify the voices of the communities that we work with and to have them as part of the conversation, as the decision makers, and have a seat on the table to say what is it that's impacting them, to be able to truly make this hyper local and amplifying their voices, and where there is an opportunity to be able to test pilots that are able to represent marginalized communities but have the potential to be taken to scale. So collaboration across private sector, collaboration with the government, leveraging research, strengthening supply chains, and creating an ecosystem where there is an opportunity for voice and sharing.
Great. Thank you. Thank you for spelling that out for us. And thank you for bringing in that nuance. Um, So while we do need to understand the nuances, I think something that happens in the climate space a lot is that there is a tendency to get overwhelmed. I'm going to pull back a little bit and ask you very simply, which are some specific areas, if you had to list, say, the top three areas which you think require urgent and immediate attention, in the context of climate change and SRH? What would be those three areas?
This is a hard one. The minute we talk about urgency, we tend to deprioritize other issues. Go back to the conversation you and I were having a little while ago, which was around when I was trying to highlight the importance of addressing men and boys. And the perception was that I'm deprioritizing adolescent girls, which was not my intention. Now, if I say that, here are areas in which we need to have immediate attention, it is not to say that there are others that can be put
Absolutely.
on hold for a while.
Yeah.
So I will reiterate that while each population subgroup, including boys and men, as we already discussed at length, have their vulnerabilities,
Yeah.
if we are to look at the gains that we are seeing globally, regionally, and at the country and subnational level, we're seeing significant gains in maternal and newborn health outcomes, which we've not seen at this pace in the decades that we've all been working in the sector. Right. And there are people who've been around longer than I have, and they've seen the the slow change, and now we're starting to see gains in the investments that have been made. So if we want to capitalize on those gains that have been made and continue to accelerate the decline, and we want to be intentional that there are no slippages, I would say that investing in maternal health, contraceptive continuity, ensuring safe abortion access, as well as ensuring that our supply chains are very robust. I think these to me would be very, very important, while being intentional in strengthening our human resources for health and ensuring that we're providing environments for them to function.
Right.
Um, if you'd like me to elaborate on these, I could, or we could pause here.
No, please do. Please do.
So, when I talk about care during pregnancy and maternal health outcomes, what comes to my mind, which is informed by what evidence is showing us, is that there is evidence on heat related preterm births, and we're also seeing adverse outcomes are very strong, and they affect mortality as well as long term child health. So we need to be mindful that we need to focus on procuring insights from low resource settings, so that we're focused on local insights and design impactful programs. Shivangi, when I was doing my research and reading up on climate and health, climate and SRH more specifically, what I saw was that most evidence at present, when it comes to the linkage of climate on sexual and reproductive health, is from high resource settings. So, yes, it is the impact on possibly marginalized groups, but these come from high resource settings. And that may not be replicable across geographies. The kind of temperature variations that one sees, which is coupled by sociocultural norms, gender and social norms, plus nutritional deficiencies, cropping pattern changes, it changes the dynamics so very significantly. So, what we need is hyperlocal evidence, which helps us understand the impact of climate on pregnancy and maternal health outcomes to be able to design interventions that are helping us sustain the efforts that we have made, the gains that we have made in improving maternal health outcomes.
Right.
Another area, as I mentioned, which is very important, is contraception. And if you notice, I have been saying contraception and not always family planning, because contraception is when we frame it as contraception, we're looking at a wider cohort of population subgroups that are able to access it. And within that, what is important is to ensure continuity. So it is about um, product diversity as well as continuity. At different points in an individual's life or a couple's life, there are different types of contraceptives that one needs to use. And we need to be mindful of responding to the demand for services in that pattern and ensuring continuity, not from the perspective of X person is a Y method user versus through their reproductive life, what are the kind of contraceptives that they require, and how do we ensure service continuity? How do we ensure that stockouts don't happen? And how do we ensure that displacement-led changes in unmet need and unwanted pregnancies are addressed in our program adaptations? So we need to look at where is it that we need to have focus on reversible contraception, where is it that we need to have a focus on self-care, how do we ensure focus on long-acting reversible contraception, and how does that scale up happen based on client feedback so that we're able to adjust programming. So that to me is a very important area. Another area which is very important to me would be access to safe abortion. So, when we talk about a safe abortion, why is that an important area along with contraception? Is, when we look at disruptions in the health system, what tends to happen at some time, sometimes, is that due to the increase in distance with the health facility and other priorities that come up, your confirmation of pregnancy sometimes gets delayed. And when that happens, sometimes it also impacts the decision making that individuals or couples or families make about continuation of a pregnancy. Now, if that decision is further delayed, it pushes people into later procedures which may not be easily accessible close by. So we're looking at disruptions. We're looking at overall, challenges in the ecosystem, and then you have to access a health facility which is far away, a procedure that requires multiple, approvals and skills, and there is a possibility of the impact on the choices that one is making. We know that there is evidence that shows that medication abortion is a method of choice for very many women. So, what is it that we can do to strengthen access to medication abortion, strengthening referral networks, leveraging telemedicine, so that we're designing our priorities in a way that we are ensuring SRH services like abortion, like contraception, are getting the most due within the changing and evolving climate context. And of course, I will not miss here on saying that our investment in our human resources for health, specifically our frontline health workers who are women uh, in a large majority, and ensuring that they are getting the kind of infrastructure to be able to offer high quality continued services. So if we could invest in three climate-proof SRH pillars, if I may say so, for me, that would be antenatal continuity during pregnancy, reliable contraceptive access, and decentralized abortion care by providers who are supported to offer seamless and high-quality services.
Great. I love how you made that a very clean continuum for people to follow. And on that note, and this is going to be my last question, unless you say something that spurs me to ask again. But what I want to ask is, if we zoom out a little bit, and at the policy efforts level, we try to figure out how it is that we can make our systems more gender responsive. And having spoken to you over this discussion, I want to be mindful of the way that I use gender responsive, really. Also, because while women and girls are obviously affected in the larger scheme of things, we do tend to lose out on a lot of information and intentionality when it comes to men and boys. So, keeping all of that in mind, how can we augment policy efforts and, program interventions to strengthen gender responsive SRH in the context of climate change?
That's a great question. Thank you very much. So for me, when I think about gender responsiveness, I would first want to frame it as gender intentional SRH services, and looking at a policy and program framework that has equity and voice as an organizing principle. When we keep that as our bottom line and we're mindful that we are looking at it from an equity lens, and we are ensuring that there is voice for diversity, there is space for diverse voices to come in, we are starting with a more egalitarian setup from the beginning. And when we couple that with hyperlocal insights, as I was just mentioning, and design solutions that respond to the marginalized groups, being mindful of what is it that they are articulating, we're better equipped to build scale in ensuring quality services. I already referred to, a series of WHO publications and the Lancet Countdown, and they have repeatedly highlighted this. So, what is it that we need to do at first is that we need to be intentional at creating a collective voice which reiterates that climate has to be part of national SRH guidelines. It is not a supplement, it is not an addendum, it is not disaster preparedness, but it is routine SRH service deliveries. They may be defined by different departments or units within the ministry, but there has to be an intentionality of having climate integrated into SRH guidelines. And we specifically need to ensure that we're bringing in the focus on climate and pregnancy, climate and contraception, climate and abortion, climate and health list. And this is not just about plans and checklists, but it is the ethos that we adopt. Um, the other thing that I would think would be very important to do is, how do we leverage and focus on minimizing delays and disruptions in supply chain, or let me flip that, augmenting supply chains to make them more robust so that we are factoring in changes in patterns, whether we've already done that in the past for movement, how crop, whether it is crop cycles or festivals. Let's start to now also do that based on climate and build that in so that we are able to specifically measure who benefits from what intervention and who is left out in such scenarios, thereby being very gender responsive and gender inclusive when it comes to allocation of funds, designing of service delivery interventions. And to me, an area which is very important is engaging our target audience. Till the time we have this paternalistic approach of what we do for them, how do we protect them, the services that we aim to provide, we're going to have this approach of what we think is right. How can we ensure that when we are doing these hyperlocal designs, we are co-designing interventions with women, with adolescents, and here I'll be intentional in saying adolescent girls and boys, and are also mindful of informal workers so that we're being mindful of protecting autonomy and agency as they deem fit for themselves. And it is not us sitting in high power situations and positions to be able to make that decision. One cohort that I haven't necessarily talked about a lot is meaningful youth engagement. So we do have that now at every platform, but how do we now make it intentional from just being present, right? So being mindful of that. So for me, it's not just about checklists, it's not just about additionalities, it is about shifting design power to the people most affected and finding solutions that preserve their choice and dignity.
Great. I love what you said in the end, and I think that's the takeaway from this entire discussion for me, and I hope anyone who's listening to this also resonates. Thank you so much, Medha, for bringing that out so powerfully. Before we close, I want to know what are your thoughts on how to proceed, or really what do you have to add on the discussion on climate impact on sexual and reproductive health? Any closing remarks?
Thank you, Shivangi. As I was thinking about the issues that we discussed, I do feel that there is an important aspect that we need to reiterate, which is the partnership of global, national, and subnational interventions, right? It is very important to have a vision, which is where I was talking about unified guidelines at the national level, which integrate climate from the get-go. That creates the scaffolding. In my earlier point, I said we have a grounds up movement which creates the scaffolding, but at the same time, we also need that national infrastructure, that prioritization to be able to bring the right kind of opportunities and voices in. So we create that at the national level, and then we have the flexibility at the subnational level to be able to anticipate and adapt what is locally relevant from a climate risk perspective, so that services are designed in a way that they meet the national guidelines but are also responsive to the communities that they are aiming to serve, and ensuring that there's continuity. Now, for continuity also, you do need a central point for your supply chains, your mechanisms, your data monitoring systems. Um, and within that, how do we create what needs to be centralized and what needs to be decentralized. I think those are conversations that needs to be had with diverse set of stakeholders, so that we're acknowledging the role that an individual can play themselves, where they need some support and where systems need to respond and create ecosystems for them, keeping choice at the center, ensuring that there is an intentionality on preserving reproductive autonomy, and that the services are person centered. So it is an important mix of what is driven from a policy paradigm at the national level, incorporating voice of people who need the services and leveraging the system within, whether it is for supplies, whether it is for services, whether it is for capacity, to be able to deliver effectively.
Right. Um, yes, that makes a lot of sense, and thank you for bringing that in because it is one thing to say that we need hyper-local inclusion and decision making, but perhaps it is the global and national spaces that need to have the space to bring in those hyper-local voices and decision makers. So, on that note, I'm going to first of all thank you. Thank you so much for bringing those very, very thought-provoking ideas onto the platform. And I hope this is the beginning of a continued conversation because this is obviously not something we are going to solve in one day. And we're not looking to solve this in one day. And I hope that as we move along, we have more voices, more diverse voices, not only in the spaces where the decisions are made, but in also in spaces where knowledge is shared, which is the intention of this podcast, which is the intention of starting this conversation with you. So thank you very much for joining us today and for bringing in the intentionality that you did really of making sure that those who are not often discussed in these conversations are brought in, and perhaps as we go along we'll have people speaking for themselves more and more. Thanks a lot, and I'll see you in the next podcast.
Thank you, Shivangi. It's been a pleasure, and I wish you all the best as you take this agenda forward.
Thank you for listening. Stay tuned to our channel as we delve deeper into the climate impact on sexual and reproductive health in the coming weeks.